Good afternoon, dear colleagues, friends. Welcome to TNT Symposium organized by Terumo, left main and complex bifurcation stenting. My name is Goran Stankovic, international cardiologist from Belgrade, Serbia, and I have privilege to co-chair this session with Jean Fajadet and his team from Toulouse. And we also have very respected panelists, Mirvat Alasnag, Adela Minian, Michael Angioi, Gennaro Sardella. Today we have two cases which will be transmitted and done live in the Toulouse, in one of the best centers. And our goal is to discuss treatment strategies. One of the cases will be left main, the other one non-left main, but complex bifurcation lesion. And I think it's important to learn and to discuss why left main is different from other bifurcations. There are certain anatomical characteristics which make left main different from other bifurcations. But of course, we need to learn how to perform PCI in complex bifurcations utilizing modern devices and latest generation drug-eluting stent. So one of the objectives is to understand the best treatment options for patients presenting with left main and complex bifurcations, but also to discuss comorbidities like coexistence of valvular disease, aortic stenosis. Then we need to learn how to optimize both the strategy and the technique. We can do bifurcations using provisional philosophy and provisional stenting strategy, but in complex case scenario, we can use upfront two-stent strategy. And we have one of the best operators in the world to help us learn and follow him. And finally, of course, the goal is to understand mechanical properties of the Ultimaster Tansei DES and share the latest clinical results, having Dr. Serra, one of the best presenters of the CTO club, bifurcation club, all complex PCI. You can find his name, and I'm sure we can share and discuss the data of the Tansei stent. This is the session flow. We start with the case presentation, we connect with Toulouse, and after that we have time to discuss the strategy of patients that will be treated in the first session. After the first case is finished, we have presentation of the Ultimaster Tansei technical features and results in left main bifurcation approach by Dr. Serra, and then we go back to Toulouse for a second case, and we will have time to react at PCR. Please use your cell phones and use the application to send questions. It will help us understand demands and go and learn together with you what are contemporary questions that we should cover. So the patient number one is a symptomatic patient with LAD diagonal bifurcation lesion. It's a lady, 71 years old, 160 centimeters tall, body mass index of 23, and risk factors are hypertension, dyslipidemia, and family history of cardiovascular disease. She has very active lifestyle and normal cognitive function, and she presented clinically with angina class 2. No signs of heart failure, ECG is normal. Coronary CT angiography was done and documented multivessel disease that was indication for performing coronary angio. Lab investigations are within normal range with creatinine of 63 and GFR normal 84.8. Normal troponin, and this is baseline angiogram. Take a look if this patient is in your lab. I'll show you more images, but you can clearly see diffuse disease and long lesion in diagonal, as well as a long lesion in the LAD. In multiple projections, we need to select the best projection to visualize the other segments, but I think that this one in LAO caudal clearly depicts complexity, and if we speak about complex bifurcation treatment, this is something really belongs to that category. Right coronary has some moderate lesions, And if we speak about risk evaluation, we have only LED diagonal. Syntax score 1 is 7, and Euroscore 2 is also low, 1.3. So to summarize, nice lady, young, 71 years old, angina class 2, coronary CT angiography shows multivessel disease, and on angiogram, you can appreciate a long LED diagonal bifurcation lesion. Our goal today will be to find the best treatment strategy and to learn from team in Toulouse how to approach this kind of complex disease. So we have now time to discuss with our panelists their opinion about clinical presentation and about clinical indication for performing revascularization. So Mirwat, if this is your patient, what do you think, what would be your approach?
So from a clinical standpoint, she has angina, and you have two vessel disease, the LED and the diagonal. One reservation I have is about doing a CT scan in an elderly female who's over the age of 70. I'm not sure it's going to add a whole lot. Likely there's going to be calcification. CT-FFR is something that's up and coming, but it hasn't been standardized universally, and it's not available, and it's not really something practical. Either some kind of non-invasive ischemia assessment, or if you're going to take her to the lab, then perhaps do some physiologic assessment, followed by intravascular imaging to determine the nature of the plaques, and then strategize accordingly.
And then strategize. Angiography seems relatively complex, isolated bifurcation, but Gennaro, what do you think?
The problem is always the same. If basically on angiography, or to go to investigate better with imaging to better understand the classification of this bifurcation lesion, it's always the same. If we look the angiography, it could be 111, maybe 110, but sometimes we have some surprises with imaging, and according with imaging or to the final classification, we can choose a strategy in terms of culotte, crash, or something like that.
It will be most probably upfront two-stent strategy, and then it's operator preference.
Yes, maybe in my opinion, maybe two-stent strategies more.
Yeah. So, Dr. Aminian, access site, one of your specialties, and you have a study, radial, femoral, 6, 7 French.
If you go, depend on the strategy, but first I would go for a slender sheet, because when you use the radial access, it's always good to have the thinner sheet that you can use. So here I will go probably for a 6 French. Yeah. It's not a left main, so you don't need a very large balloon and large stent. So I would go for a 6 French slender here. With the outer diameter, it's 2.46, so it's a nice downsizing according to current standard sheet. I will not. Maybe for the next case, I will propose, it's not yet depicted, the next case, but it's a left main, but I would go for a 7 French for the next case. But for this case, I would go for a 6 French slender.
It's 6 French radial. Michael, would be the same, 6 French radial?
Yes, I think the objectives are well defined, and I think 6 French is enough according to the vessel diameter, the branch, and we don't need to have a 7 French.
Okay, let's see what team in the Toulouse has to share with us. Now we're gonna connect. Jean, good afternoon, Jean. We are here. We can see you in the lab, ready to proceed. Please introduce the team.
Hello, so il faut mettre les diapositives. Good afternoon, and really happy again with Bruno and all the team to participate to this TNT Turumo session. So you have already presented the case, we have already discussed the case, and Bruno, the objective today
is how to perform this quite complex bifurcation LED diagonal bifurcation lesion. And we intend here, and it could be discussed, to use a decay crush technique. I think that the rationale here is to stent first the diagonal, because we have the feeling that this diagonal, it's a large branch, he has to be protected because he's supplying a large amount of myocardium. There is different technique possible, but we decided for the decay crush. So we discussed over the strategy, 6 French transthreaded approach using the slender sheath. Then extra backup 375 guiding catheter. We will wire the diagonal and the LAD with a run-through, predilatation and Ultimaster Tansei stent in the diagonal branch. We'll crush the diagonal stent. Then we'll do a first kissing. Then we will, after this first kissing, put the stent on the LAD. Then doing a second kissing and finishing by the final pot. So this is the team, Jean Fajadet, myself, the nurse Sabine and Emily. The anesthesiologist on the back is Madi, and we have as a radiographer Corinne. And the little angel on the upstairs with the technician is Clémence, who is taking care as a medical coordinator.
So thank you very much. What we can do is to show you the slide that we have already done. As Bruno tell you, we are with XB 3.5 6 French guiding catheter. And you can see that we have first a very, very large left main, a good circumflex artery, and you have here definitely this disease on the proximal and mid LAD associated with this lesion at the origin and the proximal portion of the large diagonal branch. So the goal today is to treat this bifurcation lesion, what Bruno tell you, by using a decay crush technique, because we think that this diagonal branch has a critical severe lesion at the osteum, and I think it should be better first to treat this diagonal, prevent any closure of this diagonal, and then follow by the LAD stent and using the decay crush. So this is a goal. Now we are here. I can show you all the views. This is another view in caudal view, the LAO 13, caudal 20. And in the spider view, here is the lesion. The lesion is starting on the diagonal. It's quite a long disease from the osteum, around 1 centimeter disease. And really, we are afraid by stenting the LAD, we could have a closure on this diagonal. That's the reason why I think for this particular case, the 2-stent strategy will be a good solution. So what we can do is to advance the first run-through wire. We could use this view, which was...
Maybe we can have the opportunity to ask to the panelists what will be their strategy with 2-stent, if there was decay crush or maybe inverted destenting or other possibility. So we have the opportunity to discuss with them what could be.
Yeah, thank you very much, Bruno. We already discussed presence of diffuse disease in both branches. This diagonal is the only diagonal going up to the apex, so it's definitely, according to all the studies, clinically relevant side branch. And I fully agree with you that it needs to be incorporated in treatment strategy. Dr. Serra, what would be your personal preference if you agree up front on the 2-stent strategy? Which one is your favorite and why you select that one?
Well, I guess that in that case that you have an angulation between the LAD and the diagonal branch, which is less than 70, is clear with that anatomy, with that 011 or 111, that you have to go to 2-stents technique.
And favorite one for your center?
It's difficult to say which one is going to be better in that specific situation in LAD1. I guess that either decay crush or the culotte technique, both are good strategies for that. And I guess that in that case is the one that you feel more comfortable, the one that you have more experience, that you have to choose. That's my point.
You know all the steps. You don't need to think what is the next step. I know that, Mirvat, you are using decay crush frequently. I saw your cases. Would you agree on decay as upfront two-stand strategy?
I would, primarily because I want to make sure I can access that side branch again. So I want to secure it up front.
Other panelists, would you select different, or you agree on decay crush?
I think there are two options here. This is an important side branch, as you have said. So you, as a definition, you don't want to lose it. So I think the main reason to put the stent first in the diagonal is to not lose it, of course, and to secure your access. Another option, which is suitable, I don't know what the panelists are thinking about that, but is to go first to the main branch, open the side branch, but the problem is that the disease is diffuse and go beyond the ostium. That's the problem. And you can do a dilation and then decide if you put a stent or not, and you can do physiology. So there are many options that you can, but probably decay crush if you want really to secure the side branch, but at the price that you put two stents. And this is always.
But if you decide on two stents, why not culotte? Why decay crush? This is the question from the audience.
Because personally, I don't like to have too much overlap in the proximal segment, and especially because here you have a relatively big difference between the diagonal and the LAD. So I would expect some kind of malapposition proximally. So or if I do a culotte, it's going to be a very short culotte.
Mini culotte.
Yeah, mini culotte.
Rino, what would be
the more tight stenosis is on left diagonal, on the diagonal branch, but the stenosis, the disease on LAD is very long. That is better decay crush because culotte with this long lesion could be a little bit dangerous, I think. That's decay crush for me.
So, Michael, you also agree?
Yes, I agree. The angle between the two vessels is the main point to use a decay crush instead of doing a T-provisional stenting. Because once you have implanted the stent in the mat-limb, you don't expect to have a good result or with a tap, for example, according to the angle of the lesion.
Yeah. Will you stent up to the ostium of the left main? That's another question for our panelists or for the team, of course. We see that Jean has successfully placed both wires distally. Jean, there is a question from the audience for the placement of stent into the LAD. Are you planning up front to go up to the ostium? You think there is enough space? Yeah, in this projection, it seems it's feasible.
I think that we have 8-10 millimeter length between the ostium of LAD and the bifurcation. So what we will try to do is to advance now the predilatation balloon in the diagonal.
It's a 2.5
severe lesion. It's a 2.5 balloon, and so here we are.
Okay.
Prépare à tester.
2.5 by 15, huh?
Yeah, it's a 2.5-15 balloon and test. Okay, here we are. We can inflate here. And then we will see the length and the diameter of the stent that we need. Well, it's okay, it's open. Do we need longer than that?
But we need to crush it. So.
We have to crush, so it should not be longer, more distal. I don't think so.
Maybe 18 should be...
So the 18 should be okay? What do you think?
I think 18 should be okay.
Okay.
What do you think, Goran?
I agree with you.
Is quite short.
Yeah, in the range of up to 20, maybe 22 will be okay if you crush 2 millimeters proximally. The advantage really, and there is evolution in decay crush technique, that you really do minimal crushing. You minimally overlap proximally inside the main vessel. And by performing POT 2 times, I think this is really something that makes this procedure one of the most predictable ones with the best apposition of the proximal stent.
Where?
22, I think.
The 5 ou de more?
21, 21.
De 275 ou pas?
275, 21.
275, 20.
Jean, you are using 6 French 375 EBU?
This is a 6 French XB 375, and
you need a balloon in the LAD.
We'll see the. So now we need to place the balloon in LAD.
What is the diameter of balloon in the LAD that you will use for crushing? This is one of the frequent questions because whether you are selecting size according to distal LAD diameter or according to proximal.
So we try to use according to the, I would say, in between, because proximal is at least 3.5, maybe more. Distality is around 2.75. So we will take a 3 millimeter balloon.
Yeah.
And I think that it will be okay.
Yeah.
So
what do you advise,
this
Goran?
is the stent.
Yes, this is the step.
You know what we advise, and we are trying to collect more data, is to go usually with slightly oversized balloon but lower pressure, or do 2 inflations, one as you do according to distal LAD diameter, and then like pot, balloon that you will use later on for pot, you use like performing the first pot and crushing better just up to carina level. If I try to explain clearly, it's much easier if I have possibility like yesterday to draw, then it's picture says more than 1,000 words. But I hope you understood. So you do like first pot at the moment of crush.
15. Yeah.
Okay, so now we have placed the stent in the diagonal, a little bit protruding in the LED. We leave it at that point, and then we will place more precisely. Okay, 3-0 balloon, please.
Yeah, lesion in the LAD is long and diffuse, but intermediate. So there are questions from colleagues in the audience. Is it necessary to do FFR evaluation, or it's intermediate lesion, or in the projection compared to proximal diameter, it's clearly more than 50% diameter? What is your...
First is more than 50. Second, first is more than 50%. Definitely is around 70 in some views. Second is it's a long lesion. Third, we have to treat the diagonal. And if we treat the diagonal, we have to place a balloon somewhere in a lady, whatever the technique. So if we place a balloon inflation, we have to stent it.
Exactly.
So that's the reason why we do use a decay crash.
Maybe we can go in the caudal view.
We can go in the caudal.
Sorry.
Attention.
Sorry.
Yeah.
It's okay?
So for our colleagues in the audience, if you have to inflate balloon in the intermediate diffuse disease, you will definitely traumatize, and that has to be stented. So in this case, by selecting upfront decay crash, we are determined to stent also intermediate disease in the LAD.
Yeah.
So what do you think? I advance a little bit more per distal the stent. I will show you again what you have seen, and we will try to place the proximal marker of the stent a little bit more distal in order to avoid too much long crush segment. We can take another view.
Yep.
Go on.
Mirvat, are you happy with the position?
So this spider view or the LAO caudal is going to pinpoint the origin of the diagonal and help you position the stent. But the REO caudal is going to tell you how much proximal length you have in the main vessel or the LAD, which we're considering the main vessel right now. And will tell you how far back you need to be in the LAD so that you can comfortably pot once you've deployed your stent. So you need to know how much room you have there.
Excellent. In this projection, this seems
foreshortened.
Foreshortened.
Okay. Okay, so I deploy the stent.
Now Bruno is deploying the stent first.
So just...
okay.
10.
10. C'est large, hein?
Yeah.
So you are deploying at a nominal pressure.
Yeah.
Yeah. And now we will pull back the balloon.
Yeah.
And now high pressure inflation at the ostium.
Slowly.
Yeah.
Yeah, you can also, Jean, post-dilate the ostium of the stent in order for easier recrossing. This is another recent adventing. I think it's very important to have excellent expansion of the stent in the ostium. By flaring the ostium, you can really cross easier afterwards.
I think you can do it.
Okay, with the same balloon you want?
Yeah, with the same balloon.
You do it. Go on.
Let's see.
Yeah, so go on here.
No, but
Yeah, I understand. With this balloon.
with this balloon, you have to re-advance the balloon.
Yeah, but
something
it
like
should
a
be
reverse
inside
spot.
the LED.
Got it.
Yeah.
Something like reverse
Like
spot.
a reverse spot.
Reverse spot.
Yeah.
No more than that. The test-
There is a recent publication showing that if you post-dilate with the same balloon at high pressure, recrossing rate was more successful, and by using OCT, you see that it's much easier and much wider area and cell opening.
The concept is the same.
Yeah, so the concept and the team from Toulouse is always teaching us how to do it properly. You actually try to go step by step, taking all the advantages for perfectionizing each of the steps in order to have optimal result at the end.
Just keeping the position of the balloon.
Yeah.
So now we can remove the wire.
You want to
This
test?
is the wire. I think it's okay.
Yeah, looks.
I hope there is no test. There's no dissection distal.
No, it's okay.
It's okay.
Yeah.
Okay.
So we
can
make sure
remove
there is no
wire.
distal dissection, and then we remove wire from the side branch.
Okay. This is done.
Yeah.
And now what we will do is to inflate the balloon. We crash it.
Okay.
Ready? Okay, Bruno. Okay, now we crash. This is the crash of the stent with a 3 millimeter balloon.
Yep.
Okay. And now we will remove the.
I inflate at 16 atmosphere.
Yeah,
because-
16 is good. So,
Yeah, we saw fully open balloon, so probably the effect was reached.
okay, this is a LED wire.
This is the LED wire. But did you remove the diagonal? Yeah,
Yeah,
that
yeah,
was on
yeah.
the
Everything
table.
was
Okay,
out.
perfect.
And now I remove the LED balloon. You get it?
Yep. And then we do a test.
We will do an angio. And now from the angio, we will see if we could...
Okay.
Donnez-moi notre guide. Hein? Okay,
So
this
we
is
see.
good
Yeah.
Yeah,
in this
looks-
view. So what you can do is take another wire
Yeah. To do the first kissing.
and to do the first kissing.
Yeah.
Envoie le...
With this dilatation, the distal part of LED, it look like more tight than before. Eh? If you, with
Yeah,
the
but by
dilatation of the
inflating
proximal
balloon,
part.
yeah, by inflating balloon,
it's a
you
long
have
lesion,
some.
It's a long LED lesion.
Now you can see the stenosis
Yeah.
of LED too.
By inflating balloon, you have some plaque
Yes, of course.
distribution, of course, and it's also response to
And if you take, maybe we
barotrauma.
can take the color
What wire
view.
do you like to
You will see
recross
Fajadet
with?
first for crossing.
What do you prefer recrossing with?
Recrossing point. Yeah, this is what we learned from bench. In decay crash, since you are compressing balloon, you actually create small artificial gap at the carina level. And this is the only two-stand technique in which you try to cross either centrally or proximally. And if you are able to do a really very short segment of the stand crushed, then it's more important to go more proximal. So, Jean, do you agree with that strategy to cross more proximally stand?
I will try to do it, but you know what I say every time. I was so happy to place the wire in the vessel that sometimes I'm not sure that I cross distally or proximally. But I will try to do it.
But
so I will. We want to show you the last view. Look at the LED disease.
Yeah.
On the mid segment. Yeah, definitely it's a big LED, and so we have to stent it.
Yeah,
so now
it's clear.
we will start from here.
You're going to go, okay.
Test. Normally it's proximal to distal, but here we are in proximal.
So it's still a run-through wire that
It's
you
a run-through wire.
Yeah?
So you
we
work
take
with
exactly the
workhorse
same wire.
wires.
Yes.
Yeah,
Okay.
and
this is the run-through, and you see that it was
we
easy
saw it.
to
It's
to
really
place.
after
So we have
performing
this-
after performing pot-like inflation, crossing was very easy. At least it seemed from our perspective to be very easy. But of course, in expert hands, everything works much easier. Any guidance how to choose balloon? Mirvat, it's according, we already discussed, according to distal or slightly bigger than distal main vessel diameter. You have other tips or you do the same?
2.5 and
I'll do the same and much less experience, so I can't eyeball. You would use imaging, intracorneal imaging. It's a cheat sheet for me.
Tony, you have experience. It's
I mean, in that case,
visual.
yeah, visually, which was a 2.5 to dilate now the cells, the two-layer cells of the LAD, and then do the first double
The
kiss.
first kiss.
The first kiss, and maybe I will go to the 2.5 in the LAD.
Yeah.
Because we are very close to the left main.
Yes.
And I don't want to have a dissection proximally. So I will keep on the safe side, 2.5 on the diagonal, and 2.5 on the LAD. I don't know if,
Let's see what Jean has
I
selected.
don't know if Jean will agree with that.
Which wire was run through, so we already answered that question. So we work with workhorse wire, and then in case we have difficulty to cross, we go usually to hydrophilic.
Non, et le 2.5, c'est combien? Ah non, j'avais dit 15. So,
Which balloon is that, Jean?
but the balloon, this is a 2.5
Okay.
and some difficulty to cross.
it's not usual. So probably we can try with a 2.0 and go
Well,
back with,
we will take a 2.0.
and
Yeah,
come
you
back with a 2.5
undersize.
thereafter.
You
I don't
undersize
want to-
slightly.
Yeah.
Yeah,
Donnez un
Yeah,
2.015.
I prefer 2.0.
yeah,
2.015.
Envoyer un 2.0 par 15.
yeah. Okay, so wire is removed, now recrossed.
5 on the table. It's unusual, but
In the past,
Okay,
we
so
used
it's
to
a
go
2015.
always from smaller balloons and then slightly undersized to create space, but new generation of balloon is really so low profile, so flexible. It's
And I will say also that stance is very important because that stand has a two-link design.
Exactly.
So two-link design make a larger cell, so make it much more easier to recross a double layer.
I have a question to Dr. Stankovic.
yes.
I know it's a DK crush, a double kissing crush technique, okay? But just
true that
could
sometimes
you explain us why you need first to do a kissing? Why not just opening the strut of the crush stand? Because sometimes in my cat lab, I know some operator just open the strut and then go with the main branch and then do the kissing.
Yeah,
but the first kissing is not completely mandatory.
Yeah.
So what, can you just give me your your
I'll
advice?
tell you. I spoke with Shaoliang Chen, so it's not my interpretation. I had the same question for him. So he said if you just inflate balloon in the side branch, you push metal into the LAD. And he doesn't want to displace metal into the LAD. That's why he's inflating gently two balloons to keep metal at the carina level, not to push metal in the LAD, and then create potential issue of recrossing.
Makes sense.
So we have difficulty to cross, and you see?
Very curious, because the wire, absolutely no difficulty to cross, you see.
Yeah, you see.
And
Do you think
curiously,
an extra support wire maybe could help? Or?
But I think I agree with
help,
Jean.
yeah.
It's better to select another cell. Probably this cell was one of the edge cells, so it's easy to cross with the wire, but then you don't forcefully insist to go with balloon.
Can we film it?
Yeah, we can.
No, you are not.
in. We are not in.
Or it could happen that the wire is crossed under the struts.
Okay.
Under
But
one
you
strut.
see now with the different, cell,
It works. Yeah.
it worked. Bravo, Jean. Thank you.
And also the expert hand manipulation, which is more important.
Yeah.
So what is
Yeah,
to
but,
have the guide a little more coaxial, and the other thing is crushing. So you may need to crush again.
If you still
if you
face
ca- if-
difficulty,
yes.
you use bigger balloon, 0.5 millimeter, and then you crush more proximally.
Do you use a non-compliant balloon for the first?
If you, it's recommended usually, but you face if you face difficulty,
You
you
go
then
for-
exchange for soft semi-compliant because of the lower profile. But I said new generation of balloons is really remarkably low profile, easy going into devices. It's really first choice non-compliant, and only if you face difficulty then you replace for semi-compliant. So now you are going with balloon into the LAD. You heard
LED,
our comments.
To be sure that there is no problem.
Yeah.
To be sure there is no problem, because it's not usual to have this kind of resistance
Yes.
at the ostium of the side branch.
Yeah.
Particularly with this kind of low-profile balloon. So,
And
let's
which
see what
balloon,
is
Jean,
the-
you selected for LAD?
ce ballon, c'est quoi?
2515.
The 2.5.
2515.
C'est lequel?
2515.
Yeah, it's perfect.
It's a 2.5 array. And but normally it's cross. Huh? Okay, LED, no problem.
Okay.
Yeah,
Okay,
without
we can
any
do it here.
problems.
Okay, we can do the first.
Test just to see if
Yeah.
we have not in the left main. Test. Test.
Yeah.
Okay,
It's
here is
better
okay.
to be cautious. It's very
We can
close
advance
to
the
left
other one a
main.
little bit. Yeah. Advance the diagonal inside. Okay, now we can go.
Okay.
So
6,
first
8.
you inflate balloon in the diagonal, and then you will come with LED balloon after that. What pressure
So
you are
12
using?
on both, 14 on both, 14 on both.
And then simultaneous deflation.
Okay.
Deflation,
Yeah.
yeah. Here we are a little bit on the side. That's why we go to quite high pressure in terms of size of the balloon. Huh?
So 1, 2.
So normally now we can remove the wire and the balloon from the diagonal and
Yes,
stand the
Sure.
LED.
And stand the LED.
Yeah,
But
next
first
step
we
is
will do a
stenting
view
of the LED.
to be sure, to be sure, because since the beginning, I feel not comfortable with this problem that we
Yeah.
had on the diagonal. It looks good. Huh?
Yeah, it
It
looks
looks
good.
very nice, and
Okay,
there is no
so,
proximal dissection,
now
which
we
is
can-
extremely important.
Yeah.
And now we don't have any more struts in front of the ostium of diagonal. So it's much easier now to recross, and if you stand, you have just a single layer of
We need
metal to
calculate the
cross.
length.
Yeah.
Maybe in cranial view. So now we have to calculate the length of the stand that we need for the LED. We will place the cranial view in order to align all the length of the LED.
Difficult, huh?
It's quite long.
Yeah.
We can do with the wire.
Yeah, if you want.
We can calculate with the wire.
But not in this. I think in the caudal view it's better.
AP view
Yeah.
or something like that, yeah. Here.
Yeah, so for colleagues in the audience, you know that it's 30 millimeter, the soft part of the tip of the guide wire, and you can approximate the length of the stand that you need.
28 should be okay, hein? Ok.
28.
Tu as 28?
3,028.
Par contre, c'est mis dans la diagonale. Teste doucement.
Test.
Okay, here we are. Good.
Good.
Okay,
What-
28.
What size would you select for stenting of the LED?
No? I think it should be a 3-0 28 Ultimaster.
Then we will do a pot with
And then we will do
the pot with a short one, 358.
the 3-5, short balloon.
358 à queue force.
Yeah, similar to one that you used in the beginning, short one in order to avoid traumatizing the distal left main.
Yeah.
But if you see the silhouette of the stand, it's really nicely open. It was definitely soft
Yeah.
plaque.
We feel that resistance, yeah. Just a test to be sure that we are not in the left main.
Maybe
We
you
have
have to
advance
advance.
a little bit more here.
And we will control probably in the.
Just here is not too bad.
Yeah.
So you try to
want to
position
check?
proximal marker to make sure that you are covering ostium but not protruding into the left main.
Here,
It's okay.
but not the left main. Is it okay? What do you think?
Yeah, it's okay.
It's not too bad.
Yeah,
One more, just-
seems very, very good.
Good. Okay, here
Okay.
we can open the stand now. Good.
Yeah, of
So we
course,
can,
thank you,
zoom
Mirvat.
the image
Now
and you
with
could
this
see
tent, we are crushing again
first tent, we
whatever was protruding.
There is a
And
large
you see
area.
that stent is really very nicely visible, almost like at the zoom, like using stent enhancement software.
Bon, on remet ça de nouveau.
Don't you think
3, 5,
that
8.
sorry, the stent of the diagonal is a little bit quite inside the LED, or because we see on
But
the
depends from projection
Yeah.
to projection. So
because regarding the projection to place the stent, the spider view was maybe not the best view. No, would you go for a cranial left view, for example, to see really the carina? Because
I think it's operator preference.
No, I know, but
Mirvat said RAO because shows you, I don't know,
Yeah,
you know
maybe,
what
maybe
would be your-
in this view it's more visible the distance between the left main, the proximal LAD, and the landing of the landing zone of stent. You are right for the first view for the first stent in the diagonal branch. It was right. I think that it's a good view for the.
Yeah. And now, after you see now balloon, non-compliant balloon. Is it non-compliant? What size of the balloon you select?
Yes, non-compliant.
It's an NC balloon,
Okay, and
358.
3.5 by 8.
Yeah.
3.5 by 8.
Yeah, I think it's very appropriate sizing, and it's short enough to stay inside the LAD.
Yeah, it's okay.
Yeah.
We can
Even-
come back maybe a
A
little bit.
little bit back. Huh?
Yeah, you.
You see, in this view, it's look like more compressed.
Yeah,
in
yeah,
the
yeah.
other view, it's along.
Yeah, because this one for shortens a little bit.
it's shorter. Yeah.
But again, 3.5 seems to be quite adequate.
what's the pressure?
It's a
18.
proximal LAD, 3.5. What was the pressure, Bruno, that you used?
18.
You see.
3.5 by 18.
So where do you position your balloon when you're doing pot in DK crush as opposed to, for example, tap?
Yeah, in tap I don't do second pot. This is my personal preference. I have no data to convince people in the room, but if you do tap, you intentionally create short metallic neocarina. And I'm always afraid when you start inflating by increasing pressure, you have a longitudinal expansion of the balloon, so you can crush carina. And in any other technique, we try to make sure that shoulders, not the distal marker, but shoulders are at carina level. So slightly proximal, and you need to know the relationship between marker and the shoulders of the balloon. So depending on the kind of balloon that you have in your lab, you have to go a little bit more proximal, more distal.
do you always use non-compliant balloon for the pot, or
No,
sometimes
no,
semi-compliant balloon?
No, in this situation, I agree completely to use non-compliant balloon. But for example, if I have a long metal segment proximally, I prefer to use semi-compliant, because by semi-compliant balloon, increasing pressure increases diameter. And this will result in better apposition of the stent. So I believe if you have large segment stented proximally, you should use semi-compliant. Jean, we saw that you recrossed again very easily.
Yeah.
Yeah.
And there was no really major problem to cross it.
Perfect.
We start from the proximal and push the wire
Yes.
to the circle, to the diagonal.
Donnez un
And you
2,515.
could see it. So now we will take a 2.5 balloon for the diagonal, a 3.0
for the LED.
for the LED, and we will finish by the
2,015 et 15.
2.15.
3,515.
With the second kissing, yeah.
2,515. 3,515.
Tu donnes 3.5 ou 3.0
Yeah. 3,0.
Kissing.
2,5 et 3,0.
Ouais, c'est ça. Okay, so we have 2.5. We will select a 2.5 by 15 for the diagonal,
Okay.
3.0 by 15 for the LED,
And then normally we should
and
finish. But
then we will finish by the final pot with
What-
a 3.5.
Dr. Fajadet, what is your anti-thrombotic strategy after DK crush? It's 6 months of DAPT or 1 year?
No, il y a 2.5
Maybe we
et
keep that
3.0.
question
Normally
for
it's-
time to react.
Okay.
Yeah, now we let operators focus on strategy to finalize. We are almost there, but few more steps to finish this complex procedure, because whenever you decide to do DK crush or culotte, you really need full concentration throughout the procedure, and I believe if you know all the steps, as you see, in expert hands, it's not that complex as it looks when you try to explain.
Yeah, we have to know exactly the methodology, all the steps, and at the beginning, when you do the first, we have the beginning experience of the decay crush. You have before starting the procedure to write it first, second, third, fourth. You write all the steps, and so then when you are at the table close to the patient, you have all the steps in mind. But this is important to start with all the steps in mind before treating the patient. So now what we can do, this one is the 2.5. I have to look at the wire because I'm not sure. This one.
Yes.
So now, 1, 2. This is a diagonal.
Maybe you can advance still a little bit too.
Yeah, we can advance a little bit more. And then what we could do is to have the 3-0 balloon.
Yeah, the 3-0 balloon.
You have it?
Yeah.
Personally, I put also balloon in the LAD, especially when you have a longer stented segment distally. That balloon, in case of difficulty in recrossing into the side branch, you can always use to inflate low pressure and anchor and stabilize position. So you make recrossing easier. But as we saw, this balloon went into diagonal without resistance.
Yeah. But it's true that when you have LAD placed in the balloon placed in LAD, you can inflate it and use it at the anchoring.
That's a
very good trick, Goran.
Yeah, thanks.
So maybe now we can move to the cranial, the caudal, the spider view.
Maybe we see better the origin of the left test to see.
Can we test? Test. Okay, here we are sure that we are in the proximal LAD, but I will be to be sure to take the ostium. Just to verify, in the spider view, where is the balloon of the diagonal, this one?
Yeah, it's okay.
It's okay. Okay, so we can inflate first the diagonal.
Okay.
This one, I think.
Yeah.
We have different color.
Please.
It's a red one. So 6.
So the sequence is you start with the side branch again.
Yes.
And then main branch.
You agree with that, Goran?
Yeah, we learn from you, so I'm waiting for demonstration.
No, because sometimes, we inflate the balloon at the same time. Sometimes I'm doing mistakes.
Yeah.
And Bruno is the first one to tell me that I'm doing mistakes.
Okay.
Go on.
Because whenever I have two stents inserted, I go high pressure separate inflations to remove all the metal and make easier final kissing, like you are doing now.
Good. Attention, se réveille.
Yeah.
12 on both. That's enough, Bruno?
Yeah.
Okay, we deflate. 1, 2, 3. That's good. So
then we will remove the two balloons.
This one is LAD. This one is diagonal.
Any tricks to remove simultaneously or separately? What would you advise, Jean?
In fact, with the
take care of the wire.
In fact, with the monorail system, we remove the balloon till the junction here.
Yes.
The tube.
The tube, and then we remove now the LAD.
LAD, okay.
And then when I am here, I take both balloon in the left hand.
Excellent, thank you.
But first we have to organize the things with the wires. You see, sometimes the wires are twisted like that. So here I have the two balloon in my left hand, and the two wire in the right hand. And I push in the right hand. And in fact, what I'm doing, I push more than I pull.
Okay.
In order to maintain the wire in the vessel. Okay, here we are.
Excellent. Excellent, thank you very much. Dr. Sardella, I heard your comment on 3 layers in the LAD stand.
The comment is not mine.
No, you commented on the question from the audience.
We must specify how many layers. It's not proximal LAD and are in just in the middle of just close to the side branch. In the proximal LAD, it's not 3 layers.
Yeah, so it's very
Because it's
short
yes,
segment.
It's a
with,
mini crash, mini decay
crash.
crash.
Yeah.
This is very important to clarify.
Okay. Why not cranial view? Yeah, we will use all the projections, so we can see now after stenting. This is why there is really intention of people to start with two-stent strategy. You remember how difficult and complex was in the beginning, and it's so beautiful, Dr. Serra, now. So you cannot resist not to recommend two-stent strategy up front.
Absolutely.
C'est le 3-5 court.
Non, c'est un 15, ça.
Ah non, pas le 15, ouf.
Non, non.
So the last
mieux un
step will be final pot, using the same
Yeah.
balloon.
Now we are, we will use a 3.5 by 8 or 10. What is the length, Bruno? 8 or 10?
8, I think 8 is the best because we have a very short overlap
That's
before the left
view
main.
In
So
this view, which is good. And in the caudal, I think it's good also, look.
yeah,
Correct, huh?
c'est un 8.
I think it's correct, huh?
Yeah.
Look. Okay, so now we have the 3.5 by 8, and we will place on the proximal part of the LED stent. If I can introduce the wire in the balloon, but but it's true what we say when you are doing a decay crush, we have to be really concentrate on what you are doing. It's really you have to respect all the steps of the procedure. Just
Advance un peu. Test.
yeah. Okay,
You see,
a
you
bit
have to-
more.
yeah.
Okay, now we can come back to the AP, for the caudal, AP caudal.
Yeah, I really appreciate that you are showing two projections, because sometimes in one which is foreshortened,
that's
it
important.
may seem to be precisely positioned, and then you go to another and you see that you are either too proximal or too
This is
distal.
okay, I think.
I think it's okay.
Yeah.
Yeah, this is coming from experience, from the
Yeah.
mistakes, you know. It's what I say all the time.
Yeah,
When you talk about experienced operators, in fact, it's the operator we have made more mistake than the others.
yeah. They say good experience
volume
comes
and at
good.
the end
Yeah,
you
good
learn.
experience
All the
comes
time
from
you
bad
learn
mistakes in the past.
That's interesting. Okay. Okay. On va voir. Very good. We
Yeah.
can remove everything.
Yeah,
Yeah.
it's really beautiful.
What we
result.
can do is to take a last view in the spider without the wire.
Not the first one, the second one.
Okay, here
Could be useful.
we can go.
Yeah,
Beautiful.
yeah, it's really
Okay.
absolutely
So
fantastic. I think.
we can come back here for the final result. Thank you.
Jean, full room here, really
I think
congratulating
that- I
you.
don't know what
If you
the
can
time
just
is.
summarize.
Maybe we have not time to go to the RIAC
Yeah,
because
we
it was
don't
quite
have
a
time. We
complex
can
procedure.
probably do
short
it
all
at
that.
the end.
So
Yeah.
we can summarize
Yeah.
from here, and if you have a
Exactly.
few questions, we
Yes.
will be in the lab to answer to you.
So,
Bruno.
just to summarize, Jean has done a brilliant demonstration of decay
you.
crush stenting.
Alone, I cannot do that without you.
Decay crush stenting strategy for a complex LED diagonal bifurcation lesion, and you have seen the different steps, and you will of this decay crush technique. And at the end, the result is quite nice and satisfying. For sure, there was the possibility to use different other technique, but we feel from the beginning that we need to put two stents. We need to stent the diagonal first, and then after you have to do the technique that you know perfectly with the mandatory steps, as mentioned Goran before.
Okay, thank you very much.
Okay.
Now we will have presentation of Dr. Serra, and we will connect again with Toulouse in 12 minutes. Thank you so much. Fantastic demonstration. Now it's really pleasure to introduce a presentation, Ultimaster Tansei technical features and results in the left main and bifurcations by Dr. Serra. Please.
Thank you very much, Goran. Thank you to the organizers for inviting me to that fantastic session. Here you have my conflict of interest. We have seen a very complex bifurcation case, fantastically resolved by the team of Dr. Fajadet. Of course, hands are extremely important in that case, but also stent design may play a major role in complex bifurcation. The Ultimaster is an 80-micron cobalt chromium platform that has an open cell tooling design that makes access to the side branch very easy. In fact, when we deploy the 3.0 stent, the cell opening diameter may be as large as 2.2 millimeters. Also, that stent has a good overexpansion capacity up to 5.8 millimeters for the big sizes, and a gradient coating that maintains polymer integrity. This is fantastically for doing proximal optimization very safely. This is extremely important to overcome the difference in sizes that we have from proximal and distal part of the bifurcation. As you can see in that graphic, between modern stents, the Ultimaster is the only one that have 2 connectors in the big sizes. Others have more connectors. So as you can understand, this translates in that Ultimaster has the biggest cell for side branch crossing in front of other stents, other modern stents. Also, cell expansion is extremely important. With that stent, we can have a cell opening as large as 4.3 millimeters for a 3.5 or 4.0 stent. This is really important because it facilitates complex through stent technique like the one that we had seen 1 moment ago, like culotte, decay, mini crush, and tap. Also, another important thing is overexpansion. That stent with this configuration, overexpansion can go to 5.8 millimeter, which is one of the biggest on the market. This is extremely important when we deal with left main and we have to overexpand the proximal part of the stent. Sometimes left main is 5, 6 millimeters. So with that stent, you will be sure that you can cover a big range of left main bifurcations. Finally, and very recently, Ultimaster has improved his stent, giving more pushability to all system by working on the exit port and making a stronger hypotube. And also importantly, they have made modification on the tip of the balloon, making more resistance to crossing calcified lesion and more resistance, which is important in bifurcation when you cross metallic struts of the stent. Finally, this enhanced push is translated even when you have the guiding catheter disengaged out of the ostium. This situation is not uncommon when we deal with left main bifurcation. So can be sure that you have a lot of push with that stent. Let's see now some data about the behavior of Ultimaster in left main. This data came from the Ultimaster registry. This is an all-comer registry in 4 continents, 50 countries that enroll more than 37,000 patients. In the interim analysis and 1-year follow-up, we identified 840 patients with left main. Those patients were divided in 3 groups. Left main only, no bifurcation is not affected. 202 patients. Patients with left main bifurcation, 165, and patients with left main plus another or more vessels treated, 473. Data and 1 year is now available. This is the baseline patient characteristics. As you can see, mean age of that population is 70 years old. Male are 72% of the patients, and they are well balanced among groups. There is a little bit of more previous CABG in left main only, and some more renal impairment in left main bifurcation, but just small differences. Of course, in the left main only, there were more ostial lesions. That's part of the definition. Whereas in the left main bifurcation, more patients had calcified lesion. Imaging was used more frequently. That's normal in complex bifurcated lesions. Direct stenting was less used in that size of patients. Post-dilatation were used in more patients, and the mean stents employed in left main bifurcation was 1.6. Here you have the clinical outcomes at 12 months in the two groups, left main only, left main with bifurcation, and left main plus multivessel disease. As you can see, results are extremely outstanding for this complex cohort of patients with a TLF and TVF roughly above 10%. What is more important I want to highlight here is the stent thrombosis. In bifurcation, those numbers are exceptional. It's less than 1% in all groups. Also, from this same registry, we have information not only in left main, but in all bifurcated lesions. In this case, we have more than 3,000 bifurcated lesions with 1 year follow-up. Here you have the baseline characteristics. Patients are a little bit younger. 77% are male. Acute coronary syndrome, 48%. You see radial access, 81%. This is a common feature when we're using this modern stent, this last generation stent. Radial access can be done very easily for bifurcations. The number of stents per patient was 1.7, and the total length of the stent, 37 millimeters. Again, if you look at 1 year outcomes in this more than 3,000 patients, you can see that TLF is 5.2%, which is fantastically good. Again, stent thrombosis below 1%. That talks about how well this stent performs in bifurcations. Also, we have more data in bifurcation group coming from a randomized trial, the Century 2. The Century 2 randomized more than 1,000 patients either to Ultimaster or Science. There was a bifurcation subgroup of 184 patients, 95 treated with Ultimaster and 99 with Science. We have now 1 year follow-up and 5 years follow-up. This is really a very long-term follow-up. And here you have the results. At 1 year, this trial was a non-inferiority trial. The non-inferiority was accomplished. In fact, this Ultimaster stent is non-inferior to Science, which is one of the leaders in the market. But if you look, again, the stent thrombosis for the Ultimaster is extremely good, 1.1%. Between 1 year and 5 years, there has been a little bit more of MACE, but not much. Again, there is no difference between the two stents, and remarkably, between year 1 and year 5, there is no stent thrombosis in the bifurcation subgroup. So this is, again, an excellent news for that stent. So in conclusion, ladies and gentlemen, we can say that in complex patients treated for left main coronary artery disease, either isolated or with bifurcation or multivessel disease, this stent showed good clinical outcomes at 1 year. In patients treated in bifurcation, data from both registry and randomized trial show an excellent performance of Ultimaster DES. I must say that what is extremely relevant is the rate of low stent thrombosis in this so difficult field. Finally, the new feature that I have talked in Ultimaster Tansei that was introduced as innovative technology, facilitate complex PCI as left main and bifurcation treatment when you have to work with a catheter disengaged from the ostium. Thank you very much.
Thank you very much, Dr. Serra. Excellent presentation, but excellent data. It's really surprising how low rate of events you have cumulative up to 5 years of follow-up, and 1% stent thrombosis up to 5 years of follow-up. It's really very convincing. What would you use for the future in treating bifurcations? You prefer two-link design with this kind of long-term follow-up evidence also for real-world patients, or you have some other selection criteria?
No, of course, this is a strong data. We have a lot of stents on the market, but we don't have data for stents, especially in this so difficult field. We have registries that involve all kinds of lesions, but it's nice to have that information because you know that stent, and I'm convinced that the stent design play a major role.
Exactly.
The fact that you have two links, that helps to recross the side to the side branch.
Yeah.
Then the anatomy of the stent the cell expansion can facilitate or makes much more easier complex to stent technology like we have seen now.
We have seen in the previous case double layer
and also 80 microns. I mean, there's a thin stent. So thin stent can adapt much better, may conform much better to the vessel. So avoiding it, and that has a big impact on stent thrombosis.
Yeah, there was a comment regarding DAPT duration. Do you think that with abluminal only coating you can shorten DAPT? What is your personal approach?
Well, there's data that you can shorten, but personally, if I do a bifurcation with 2 stents, I will not shorten. I will keep along the APT. But if you do a bifurcation with 1 single stent,
provisional,
I guess
provisional,
I guess yes, you can shorten if needed to 1 month.
Okay, thank you so much. Now we go to Toulouse again. I just need to present the second case. Can you please pop up my slides? So it's 81 years old gentleman with body mass index of 30. From risk factors, he has hypertension, dyslipidemia, very active lifestyle and normal cognitive function, but what is very relevant, he has New York Heart Association class 2 dyspnea without angina, with systolic aortic murmur 4/6, no signs presently of the heart failure, normal ECG, and on echo, ejection fraction of 70% and aortic valve area 0.8. Lab exams are again within a normal range with hemoglobin 1C 5.6, GFR 67, normal values of troponin, and this is his baseline angiogram showing distal left main disease, predominantly tight lesion at the ostium of the big circ, dominant circ. Then we can also appreciate collateral flow and occluded large marginal branch. And there was also, in the other view, clear diffuse disease in distal left main. And whenever you have such a distal left main diffuse disease, if you use any kind of imaging, you can clearly demonstrate that it's a huge plaque burden going in both ostium of the LAD and ostium of the circ. It never spares one of those areas. And here we see arrows pointing of the occluded marginal branch and tight lesion at the ostium of the right coronary. So if we summarize, syntax score is 31, Euro score 2, 2.3%. Operators already fixed in previous intervention right coronary ostium, both ostium and distally. And this is a result after stenting of the right coronary. And to summarize, we have gentleman, 81 years old, New York Heart Association, dyspnea, no angina, class 2, left main lesion with multivessel disease and severe aortic stenosis. So challenging case, and I'm glad that we have very experienced team to discuss the strategy. Few comments before we connect to Toulouse. Mirvat, Dr. Sardella, Mikhail.
So the obvious question here is the severe aortic stenosis and multivessel coronary disease. The assumption is this was discussed at a multidisciplinary team meeting and surgery is off the table. The next question is what's first? Is it going to be the coronaries or the valve? Again, I think there's agreement to proceed with the coronaries first. And the final question is when you do choose a valve, what valve are you going to choose so that you have access to the coronaries in the future should they develop in-stentory stenosis?
Thank you. I think it's time to connect. Here is connection with Toulouse. Our team is probably ready. Okay, Jean, Bruno, we are back again. We introduced the case, and we look to listen to your comments and the strategy that you have selected for this very challenging case.
You want to review the angio first, or?
So what I will like to do is to show you the angio. So we are working again 6 French, XB 3.5, and this is the first angio you see in the cranial view. And you could see very well on this view, the distal left main, the proximal LAD, the ostium of the LAD, then the proximal LAD just proximal to the septal branch, and then it's true that we have some diffuse disease in the distal LAD and the diagonal branch. So here we see clearly atheroma plaque at the ostium of the left main, the lesion at the distal left main, a lesion on the origin of the LAD, plus a severe lesion at the origin of the septal, in regard to the origin of the septal branch, and then it's a really large vessel, LAD diagonal. So this is to see the lesion, appreciate the CBT and the extension of the lesion for left main and LAD. And for the circumflex artery, we have the caudal view, not this one, here. And you could see that the ostium of the circumflex has also some disease. And that's the difficulty. In other words, it's like a true bifurcation lesion. What do you think, Bruno? We have to consider the true bifurcation lesion. The circumflex definitely is disease, and we see that, there is the plaque in this view, eccentric plaque in the distal left main.
Yeah, we fully agree with you. Yes.
The strategy, Bruno, now.
So the strategy, we are now coming back to the strategy. We will do a strategy with, we will consider that left main LAD as the main vessel. So we go through a transradial approach using in 5 French, in 6 French Gaichi slender. We will use an XP 375 or 3.5? 3.5?
It's a 3.5, I think.
3.5.
3.5.
2 runs through wire, to wire the LAD and to wire the circumflex. Yeah. We will predilate a left main LAD, then do a stenting from left main LAD, pot in the left main, because probably we will select a 3.5 for the LAD because it's the distal reference diameter. Then we will rewire the circumflex, do an inflation at the level of the circumflex, maybe a provisional strategy. We could maybe have a good result because it's a short lesion. Yeah. And if we don't have a good result, we will do a 2 stent using the tap technique. This is the plan, and we'll see what will happen during the case.
Yeah, we just received a few questions. Sorry, introduce the team, please.
Yeah, the team. So Jean Fajadet is the main operator. Myself, the nurse are Sabine and Manon. The anesthetist is Laurent. Radiographer is Clotilde. Then the angel upstairs to follow the case, it's Clémence, our fellow.
Yeah. Thank you very much. Before you start, we received several questions whether surgery was considered in 81-year-old gentleman. So before we continue, please comment on that aspect as well.
So there was a question, Jean, about the fact that if we discuss surgery for the 80-year-old patient, in fact, the target here, and if we come back to the lesion, the LAD is a big artery, the circumflex is a quite small artery, not sure that the surgeon will graft something on the circumflex. We don't present the case, and to be honest, to the surgeon, because we consider that it could be done with left main LAD as the main vessel, and maybe to be a little bit provisional or conservative on the circumflex.
Okay, thank you so much.
Oh, it's true that octogenarian patient with this kind of lesion, when we have accessible left main intervention, we will do it. Yeah. Of course, the same patient, the same anatomy in the 65-year-old patient should be totally different.
Exactly.
Or in very calcified.
Or very calcified.
It's not too much calcified, it's not heavy calcification, so we can anticipate that we can have a good expansion of the stent. Yeah. And the circumflex is not so big, so just for a graft on the LAD, maybe we can proceed by PCI.
Exactly. So complete
So maybe we can go to
revascularization
the
again
caudal
has
view.
priority. In addition to 81 years old, we know that surgeons are not happy. I mean, in studies you see different, but when you discuss at the heart team, when patient is diffuse disease, 3-vessel disease, no good distal vessels for grafting, we cannot really expect that surgeons eagerly go to surgical revascularization.
May I?
Yeah, sure, please. Doctor.
Just a question, Jean. In which case do you use a 7 French? If you don't use in this case, it is very complex case, left main, LAD, etc. Do you use in some particular case the 7 French guiding catheter?
Yeah, that's a good question. So sometimes we use the 7 French when you know that we will deal with large vessel, large stent, when we will have to do the kissing balloon with 4 mm in one vessel, 3 mm in the other, etc. Here we have, well, it's a good left main, but it's not an extra large, what we say, left main. We will see, but at the end, we will finish certainly with a 4.5 mm balloon. Sometimes if we have to finish with a 5, 5.5, and the kissing balloon with 140 plus 3.0, something like that, we will prefer to use a 7 French guiding. Because it's true that via 6 French, you could have really a problem of resistance, friction between the wire. So now we are, this is the LAD wire, and Bruno.
This is the 15 millimeter balloon.
We predilate first with a 30.
15.
This one is a 15. We could take in this particular anatomy 20. Because we could inflate in the aorta. We have to treat the ostium of the left main. So this one is 15. I advance the 30. The goal is to open this balloon quite high pressure, and then we will place after that a stent which will be certainly a 3.5. What do you think?
Yeah.
With that, we could post-dilate at 4.5, maybe 5 in proximal left main. So here we are, very difficult to see.
Yeah. The patient is quite heavy.
Yeah, the quite heavy patient.
Yeah, body mass index of 30 we can expect.
And the view, the test. I'm sorry for the quality of the angio. Maybe we will have to sometime take a cine, you know, if not. Okay, here we can place the balloon here.
Precisely position balloon and cover completely the lesion. Yeah, it's good.
Who will use the intravascular imaging in this particular left main? Who will use IVUS or OCT just to assess the real size of the LAD? Because it looks like a big LAD when you're on a certain view. Huh?
Yeah.
And the left main, it's a diffuse disease, so we don't know exactly what is the diameter. So would you rely on angiography only, or do you go?
Personally, I don't routinely really use it. It's a relatively, let's say, not so complex anatomy, predictable strategy based on what Jean has explained. And after predilatation, if you have doubt, of course, there is always possibility to use imaging. But as upfront strategy to increase the load of contrast, I would not use. I don't know, Jean, if you want to comment also on image guidance. Do you think it's really necessary for this kind of lesion?
To be honest, I will tell you that I use in rare situation intra-coronary imaging, IVUS or CT or FDI. What I'm doing, I strongly believe in the. Attention, I have to take care. That's my fault. It's not you. You see that that's a problem. I think the beginning of the guiding catheter. So here is better. Now I am in LED, and now I
keep in
will
mind
advance.
the distal reference diameters and Finel law.
I could answer for. I am doing, some imaging when, for example, we face instant restenosis, especially in the left main, because when we face this kind of problem, we have to understand what is the.
To understand what is the problem.
Where is the problem? And that is one issue. And when we have really complex anatomy or difficulty, then I use imaging at the end to be sure that the stent is properly open.
Okay, I try to get to.
It's not routine. It's selective indication.
Exactly.
And it's good. I will guess quite systematic when we have a quite stent failure, instant restenosis, to understand how to treat and what could be the solution, the technical solution. And the second situation, when you have a complex anatomy, at the end, to be sure that the result is good.
So it's true that now we
have a low flow in the
quite
LED.
a large left main. We have quite a low flow in LED. There is this section in the proximal LED.
Yeah, in pre-dilated segment.
So what we can do is to see what is the problem in the other view, and particularly for the distal LED. Ready?
Okay.
Okay, maybe it's embolization, something of air or something like that. So it's not too bad. So what we have to do now is to place, Bruno, the stent from the ostium to the diagonal, the LED to the site of the diagonal. What to do? We have to evaluate the length.
The length,
I have to pull back we have to do it. Huh?
Yeah, it's probably a longer stent that is needed to cover completely that segment.
Yeah, it's a long one, because here is 30 test. This is 30. And you see, we need a long test. One more time.
Yeah, at least 30 millimeter stent.
Yeah.
Oh yeah, maybe 38 or something. Okay, now it's a diagonal. That's a problem.
Okay.
Okay. Okay, I place the wire in the LED test again. Difficult because I'm not, and the guiding is not optimal. You see,
probably
since
the
the beginning test.
It's a good.
Yeah. Since the beginning, we have
okay, you are in a small branch.
The problem, I am in the small branch, so it's a slow flow. It could be embolization.
Yeah.
Okay, so I think it will be better if we place a stent.
Exactly.
So 3.5 by.
Lesion was pre-dilated, so
38.
stenting is, I think, next step.
38. 38. 38.
So 3.5 by 38 in order to cover all the lengths.
Exactly.
And then we will come back. Could be with a 4.0, or maybe we take the 3.5 balloon of the stent inside the aorta, and we will place 20, 21 atmospheres.
And
then we will post-dilate with
4.5.
At least 4.5, maybe 5.
Yeah. Yeah, we will see. After resolving the stent,
we will see,
we will see and decide.
Okay. So here we are.
It's 3.538.
Yeah, it's here.
Ultimaster
It's not too bad.
Yeah.
So now I have to disengage a little bit the guiding catheter in order to see the ostium test.
You are close.
So to see the ostium, maybe we need to
go in LAO
move to the LAO cranial. Something like that.
Yeah, shallow LAO cranial usually opens the most sinus, so you can clearly visualize proximal position.
Something like that. Yeah. Okay, test. Oh, it's not too bad, huh?
Maybe you can.
Maybe I can pull
back a little bit.
I can remove back, retract a little bit the stent. It's what I'm doing, Bruno.
Okay.
And now we can take a view. We can film it. Ready?
I think
here
it's
it's
okay.
not too bad, huh?
I think it's okay.
Yeah.
Okay, I disengage my guiding. Maybe you can test a little bit more. Test, please, just because I disengage, and maybe now.
You have to re-advance.
Yeah. I'm too.
So, Jean, what you are trying is to cover the roof. You want to use this projection to make sure that your stent is fully covering the ostium.
Yes. Okay, here's better.
Okay. what is important is to know where is the marker of the stent.
So we can
and
take
we know
a
that
view.
with this stent that the marker is just at the level of the stent.
I think it's correct here.
Sorry.
Go on.
Yes, I agree. You see how much careful attention we need to take when positioning the stent, because it's extremely important not to miss the ostium if you are already attempting to cover from the ostium. And in that projection, you can really open the sinus and make sure that you are covering. In one projection, cranial or caudal, you make sure that distally you are landing zone where you want to be, and in apicranial or LAO, shallow LAO cranial, you select proximal point.
So now we will use the same balloon. I pull back the balloon a little bit in the aorta in order to place the distal marker of the balloon in the stent, you see, like that.
Exactly.
And now Bruno will take a 20 atmosphere. We deliver the 3.5 at 12.
12, correct.
And now we will take 20 atmosphere in order to have this pulse dilatation quite aggressive, because 3.5, 20, we will be around 20, or we'll be around 3.7. Now we deflate the balloon. We wait for a while.
Yeah, it's important to wait in order to avoid any deep sucking of the guiding toward the stent and to have a compression of the stent.
Especially with the jailed wire. With the jailed wire, we have to be careful and watch all the time position of the guiding catheter.
Yeah, you're right.
As long as you have jailed wire, there is a risk of accidental compression of the tip of by the tip of the guiding catheter. So this is very critical to hold in the view the tip of the guiding catheter.
Beautiful.
Yeah. So now flow is restored much better, clear. So now we.
So we need to pause delay the left main.
We have to pause delay the left main. How we see 4.5?
4.5, yes.
Yeah.
12.
By 15.
15, okay, 15.
Absolutely, and that.
And then we will take care of the circumflex. We will see after that. It's interesting because remember the original view. The left main looks small, but in fact it is not small. And what is important in this patient is that we have a good assessment of the distal LAD, which is at least 3 millimeter vessel. So it means that in proximal it should be at least 3.5 because of the takeoff of the diagonal septal. And so when you look at the circumflex, which is around 2.5, 2.75, so it means that the left main will be at least 4.5.
At least 4.5, exactly.
So, so now what we will do is to advance this 4.5 balloon in the left main. We will place from the bifurcation to the ostium.
And when we advance this non-compliant large balloon, we have to take care also.
There is no resistance, you see.
Because
this is very good. So we can have a test a little bit. I can advance a little bit more. Place the distal marker at the site of the bifurcation.
Yeah.
Here is too distal. Yeah. So I have to pull back a little bit inside.
Yeah.
What we could do is to move to the cranial view, maybe.
I think
the caudal view.
We see here the maybe, no?
What you can do is to have a shoot.
A shoot, yeah.
Okay? It's not too bad here. Yeah, maybe a little bit more distal.
Yeah.
If you have difficulty to see, you can use stent enhancement and make sure that position is adequate.
Yeah.
Yes. Yeah. It's okay here.
Here it's okay.
Okay, go on.
It's okay.
4.5.
Here, by stenting from the ostium of the left main, you have really easier proximal positioning because you want to be inside the aorta and you want to flare also proximal edge of the stent, so you don't have risk of damaging proximally.
Goran, considering the talk of Antonio about the characteristics, the features of this stent, I think that according with the feature of this stent, also the tap it's feasible.
Exactly.
It's made it more feasible, except the decay crash, of course, but when you don't need to recross or you need to cross just with a balloon, I think that this stent allows this kind
it's a two-link thin strap,
procedure.
and you can really open widely, more than 6 millimeters if you go with high pressure. So I think it's a very good platform for bifurcations, especially when you need, as you nicely said, when you need large balloons for kissing, you need to favor stent with 2 links compared to 3 links.
Can you just comment for the audience about doing pot while there's a jailed wire? I know some people are a little concerned about that.
Yeah, most of our fear comes from old time when we had difficulty with old generation of hydrophilic wire, because frequently it gets damaged. But with contemporary hydrophilic concepts, you really don't have the problem to remove it, and you can keep in mind always that there is discrepancy in diameter between left main and the stent size. And even after extensive pot, you never reach really full diameter. So removing wire is not anymore that difficult as it used to be in the past. And if you have difficulty, you can always go with small balloon over the jailed wire, remove the tension by positioning proximal marker of the balloon at the edge of the stent, and then slowly remove the wire. In the worst case scenario, you can always use Corsair, and by rotating the Corsair, you go underneath the stent and remove it. So it's much more important not to go in and out in suboptimally deployed stent, especially in the left main, because frequently we don't see it by angiography. So unless you do careful pot as early as possible, I don't think you can really deploy stent, and next steps become much more predictable and safer after performing good pot. So I think what we learned in the last 10 years, proximal optimization is, I think, the most critical step in performing bifurcation, especially for the left main. So, Jean, you agree with these comments? Good
Yes, absolutely. Absolutely, we fully agree. Yeah. So, well, we fully agree of your comment. What we will try to show you is the result. In other words, look at that in the caudal view, in spider view, it looks good on the left main. And when we move to the cranial view, we have this image. So we don't know if it is the left main or the ostium of the circumflex. We give this image with an undersized stent. And on this caudal, it looks good also. Yeah. So what do you think?
I think that finally it needs an imaging.
Curious image. Look.
I'm sorry. I'm sorry, John.
No, man, I fully agree. It needs an imaging. Sure. And then we have inflated the 4.5 at 20 atmosphere. What to do? What will be the next step? Imaging show you something which is abnormal. You take a 5 millimeter or 5.5.
Even in this,
that's a problem for me. You know,
even in this view,
when you take a 4.5 at 20 atmosphere.
Jean, in the other view, it's more evident. But even in this view, you can see that there is something in the body of the left main. Here less, in this view less, in the cranial more, and the other view in the other view mid, but. Even in this view, you think that you see that there is something in the body of left main that could be investigated.
Dr. Serra, what would you do?
Yeah.
I agree with Rino. At that time, if there are discrepancies, to take a look with IBUS should be clarifying what's really happened if you need, if you have a piece of calcium that do not allow full expansion, and then take the decision according to what you see in the image.
But I agree with what Jean said. You have 4.5, 20 atmospheres, so it's 5 millimeter, high pressure.
Yes, but
I don't think that by gaining additional information you can change the strategy. Michael, what do you think?
Not sure. The diameter of the left main is maybe 5 or more. I think we can have a surprise with intravascular imaging. Yes, yes, possible.
I think you need to understand. You need to understand what's going on. Either you need a higher diameter balloon, or you have to go for specific technique, not validated like shockwave.
Yes, it's a very large LED, and the left circumflex is also very large. The left main trunk could reach 5 millimeter at least.
And even I agree with Jean that it could be the osteum of the circumflex too. I mean,
Yes, also.
sometimes in the cranial view it's very difficult
Yes, that's why.
to ascertain if you're looking at the left main, the distal left main, or at the osteum of the circumflex. You must know what happens.
Yes, that's why IVUS or OCT is a very interesting option.
Yeah. So as far as I see, Jean is trying to recross into the circ, and then probably...
Slowly. Okay, here we are. So here we are in the LAD, and now I will pull back the wire in order to place it in the circumflex. If you can. Sorry, because you have wire. Okay, here, go on.
So he just showed a really nice trick where you cross with a loop, so you know you're not under a strut, and you go into the main vessel in the middle of the stent, and then pull back to go into, so that's actually...
Yes, like that. Okay.
Oops.
I had to
Yeah. It's not easy because
just another comment
I
about
want
the
to
IVUS.
think slowly.
The IVUS could also explore the ostium of the left circumflex, because I'm not sure that the ostium is so tight stenosis. I'm not sure that we must have a stent on the ostium of the circumflex.
I don't think the idea is to go with stent immediately. It's just to recross, remove the lesion,
to do
with
kissing balloon,
inflation, and then we evaluate. I think, Jean, it's not intention to stand the circ, it's intention to open struts and perform kissing.
The intention is to do to remove the wire from the gel wire from the circumflex.
Yes.
And so we have the possibility to advance the guiding catheter a little bit more distal in the left main, because at present time the problem is that we cannot be selective because of the gel wire.
Yeah, because it fixes the position of the guiding catheter.
I need to.
Maybe the wire is.
I need to change the wire. Yeah. It's what I'm doing. I remove the wire, and I will change the curve. No, the curve is okay, but
maybe a more pronounced.
More pronounced curve. It's we will see.
Yeah, it's a big left main. You need definitely big curve at the tip. Because stent is already dilated with 4.5, so you need the longer curve.
Yeah.
And in case you have difficulty, what would be second choice? To go to hydrophilic wire, or what is your practice?
What we always do. I hope that we will cross directly. But no. You know, not easy.
Yeah, you were inside, but problem is that wire is prolapsing.
Yeah.
Or you change the wire.
Exactly. And
it's always the same.
so what I want to do is I don't want to be too aggressive with the guiding on the left main because of the gel wire. So I hope that the wire will follow the two orders. But we have some difficulty here.
We have also the possibility, because the circumflex is open, there is a normal flow, to remove the gel wire.
Yeah, that's the possibility. It should be, we will remove the gel wire, and then it should be easier to go inside the left main.
Yeah.
That's what we will do.
Yeah, that will will relieve the tension from the tip of the
If it's-
guiding catheter.
Yeah. Because here the problem is that we are not coaxial.
Okay, so we will remove, I agree, we will remove the jail wire.
So now you have to be sure.
I think
No, this is the LED.
This is the LED, and this is the jail wire. Okay.
And
So
you see
remove
that
it.
It's not gel, that's
So
all.
you remove
Now,
the jail wire.
normally, I will have the possibility to intubate more easily the left main. I can push it on it.
And
Test.
be more coaxial.
Okay.
Yeah.
It'll be much more easier.
Yeah.
And more coaxial, because I didn't do that. I couldn't do that with the gel wire. And here you see, we have the loop, we are in the LED, now we have to pull back and come back to the circumflex. If not, I will take a brand new wire. But
Okay, now it's...
normally we'll go. It was a problem of the guiding. It's, okay.
Guiding
Yeah.
issue. You see how...
So it's interesting to see that,
So now we can do is to
To see
take a
that,
5-0. What do you think?
yeah, you can go with a 5-0. If
Yeah, give me a 5-0 balloon.
It's interesting to see that when you have this facing this kind of problem, you can the circumflex was largely open. You can remove the gel wire, then you have a better cannulation of the left main, and then you can recross easily.
Yeah.
So you will
So
now
5-0.
post-dilate left main with 5.0.
Okay.
Yeah, we will take a 5-0 to post-delay the left main, and then, after 5-0, it should be difficult to move larger than that. The risk then is complications in this elderly patient.
No, but full expansion of 5.0 really excludes possibility unless there is some eccentric calcium block that you cannot remove anyway, whatever strategy you apply.
Exactly.
But the lumen created by 5.0 is really...
Interesting, the 5...
But maybe you because...
It's okay, but you see the 5 is not easy, Okay, here, test. I think...
it's okay.
Yeah, it's okay. I can intubate more.
No, okay.
No. Just I pull
you
back
will,
now. Here is okay now.
Okay.
Yeah, here.
Okay, go on. 6, 8,
Not to cross the carina
14.
with 5.0 will be...
16. Yeah, that's a problem. We have to be sure that the proximal marker is really proximal to the bifurcation.
Proximal to bifurcation.
Okay.
So the balloon looks good, here.
Maybe you can re-intubate on the balloon, and we can do a stent vessel vis to see. Okay.
5-0. You see, I can intubate what Bruno said. The guiding on the balloon.
On the balloon,
and maybe we can do a stent vessel vis.
Pulling out the balloon.
And now we can take a view.
And make sure what you see is the...
Which is good,
It's good.
the diameter.
If you want, we can do a stent vessel vis.
Yeah.
Okay, I re-advance the balloon.
Yeah. And
we will do a...
we can do the stent vis and stent vessel vis, both.
Stent vessel vis will see better, I think.
I pull back the guiding. I pull back now the balloon, and we can do stent vessel.
But we need the injection, so stent vis, because we cannot inject, we are outside. I think.
Stent vis first, and then we can...
Okay.
Okay, here. Are you ready?
So, Jean, please explain for the audience what you are performing now.
Now we are looking, at the stent boost, but with a G technology. It's called the stent vis. It's okay. And you will see it just to see the
shape of the stent.
The shape of the stent. So we have to place to leave the balloon. It's okay.
It's okay. We see that the stent is nicely round shape, and I don't think we need to do something more.
So what we can do here, maybe it's in this position to place one more inflation. You are sure
just
that
for
the balloon
flaring.
is inside the aorta for the osteum. Yes,
part.
exactly. So we are assuring that we are now inflating the balloon at the osteum in order to avoid some malapposition.
And then you will re-intubate on the balloon in order to avoid any damage.
Exactly. What Bruno said that what we will do now is to re-intubate the left main on the balloon. You see, like that.
Exactly.
And so now we can remove the balloon. Okay.
Circumflex.
Yeah, the wire of the circumflex is limit now. This is, sorry, this is the circumflex, okay.
The pressure is
Go on.
normal?
Okay.
Or
Yeah,
Okay.
we can see the pressure hemodynamics, Clémence. It's good, in this view.
yeah. And the osteum of the circumflex is okay.
In this view, it's good.
Yeah.
It's not Diffuse or
but it's
CT, but it's not too bad.
Yeah, for a gentleman, 81 years, widely open access with 5.0 post-dilatation, really open struts and provides blood to circ.
Yeah. Okay. Good.
Still
I think it's a circumflex who is doing that, because the circumflex is going there.
Yeah,
because
yeah.
maybe
we
the
have
passage zone between the left main and the osseolo LAD. It's not really the left main.
It's proximal. We will see here, but you see. Okay, go on, Bruno.
Let me recharge the contrast. Okay, reload.
With the view.
Really?
It's not really the body of the...
No, it's
It's
okay.
beautiful.
So now the question for me is, do we need to do something on the osteum of the circumflex?
That's a problem. Do we need to do kissing balloon at the osteum? That's a question. Do we need to touch the osteum of the circumflex when we have post-dilate the left main stent at 5 millimeter? Goran.
To be honest, there is no one answer that is good or bad. TIMI flow, widely open access. I mean, I'm not so convinced that we will gain, except for maybe better angiographic appearance, better flow in the circ. And personally, I would stop at this stage. You see?
There is something here.
But this is Carina shift, which is created by large post-dilatation in the distal main vessel.
On les a.
Jean,
The problem is this image.
Yep.
The image
We are
is the
waiting for your
discrepancy
comment,
between left main and proximal LAD and the osseolo of LAD. I don't think that it's on left main. It's not the body of left main.
At the
It's the passage zone between the left main and ostial LAD. I think that it's a physiological image.
But I talk about the ostium of the circ. What do you think?
The ostium of the circ, okay.
Jean, we have time to
Maybe
perform.
we will place a balloon. 2 free-5 balloon.
Yes, two balloons.
We have time to do the...
Agreed.
Just trying not to oversize balloon to circ, because that may create dissection, and in that case make...
just a 3-5 and proximally.
to stand the circ. And this is the hinge segment. Circ goes in one direction, LAD in the other. If you put two stents, you actually block, you fix the movement. So that's the reason why I try to avoid, with acceptable result at the ostium of the circ, I try to avoid stenting of the circ. But of course, if you have...
sure.
If you have insufficient
what we want to avoid is
angiographic
the
result,
double stenting. So
I mean, taking into account the age of the patient, also you can have information about if there is any blockage by FFR to the circumflex. But the problem with that patient is then you have to face TAVI.
Exactly.
So you better fix everything. Be sure that this bifurcation is very well treated before going to TAVI.
Before going to TAVI, But you see now, he crossed very easily with balloon into the circ. Now we need the second balloon in the LAD. What is very important is to select balloon according to LAD size, because you need to select 3-5 stent, 3-5 balloon. You don't oversize. If you oversize, you again push metal into the circ.
Okay, so the 3.5 millimeter balloon is there. Now we will advance.
The other 3-5.
The one is in the circ here.
Yes.
And now we'll advance the LAD one.
The LAD one. And then I will do sequential inflation starting with circ.
I disengage a little bit my guiding. Now I pull the left circumflex one.
Then as usual.
Here. I pull again the LAD. Okay, I think it's okay here. What
Yes,
do you think?
it looks
Okay.
nice.
We will think
We go?
one circumflex first, and then
Yes.
LAD.
Okay, one
And
circumflex
then the
first.
LAD, but it's important to be simultaneous deflation after that.
Yeah, I were to
it's-
re-advance the circ. This is LED.
Maybe it's too proximal, Jean.
And the
One in the circ.
Yeah, absolutely.
Yeah, okay.
Here.
Yeah,
Thank you.
that is better.
It's I repositioned, you know, because the
Thank
guiding
you.
catheter moved,
Now
and finally everything moved back.
this is better.
This
Okay,
is a
this is
little
much,
bit better.
much
Okay,
better.
here.
Thank you.
Yeah.
You have the circumflex?
I have the circumflex, I think.
Yeah.
Yes.
Okay.
So we
So
start.
it's 8 atmosphere, not aggressive.
Yes.
3.5.
And
And
then,
Bruno, you can do it again. 3.5 also.
okay.
Same. Okay, you can do 10 on both. And I will do no more than 10 on the circumflex.
Yeah,
What do you
it's
think?
fully
Yeah, it's
open
okay.
balloon. There is no reason to
1,
go
2,
to high
3,
pressure.
Down. Yeah. So it's time to remove it. Okay. 1,
One.
2. Where is the wire? It's
okay.
very distant.
Yeah.
So now
Okay, we
again,
take a view here.
Maybe
Again.
with the balloon I will have difficulty, so you
Yeah,
have to remove
we
the
can
balloon.
remove the balloon.
We are in 6 French, that is
Yeah.
the limit,
Yes.
and with the 2
Yeah,
balloons
yeah, sure.
in the guiding.
especially
do
it's
that.
non-compliant, so has larger profile, and it's better to remove at least one.
Just to say that
So
we
we
have
have
the glide sheet slender 7 French now that we use a lot for that kind of
Yeah.
complex cases. It's a 2.79 auto diameter, so it's one of the thinnest 7 French compatible available sheet. And for every
gives-
complex case, we like left main,
Yeah.
very large left main like that, we use it
And
always.
gives you enough internal lumen to...
Of course, it's feasible with 6 French, but it's more comfortable. Yeah.
Il faudra recontrôler l'IVR.
So we will do this
Yeah,
view.
in the same projection as before, just to make sure what we are comparing.
Yeah, here. Yeah, exactly.
Okay.
Okay, here we are. Ready?
Okay.
It's a little bit better. There is still some narrowing at the Oster.
But it's better. I think we can be conservative and not
Yeah,
stand.
I think so.
Maybe we can control the LED.
You want to do final pot with a 5, or after
think
the
it's-
kissing, I think it's better, no?
What do you think, Goran?
You still
I want
have
to-
balloon, but I will do pot very proximal.
Yeah.
So you
I
will,
think it's better
you
because...
will advance the LED wire.
Yeah, the two wires. Open the window. This is
This
okay,
is the
this
circ
fine.
and
This one.
and the LED.
Okay.
Perfect. So that final pot, I think, has the dominant role in proximal expansion, not in distal. Distal, you do
diagonal,
short overlap of 2 balloons. I don't think damage of the
We can leave in the diagonal.
Yeah.
Okay.
damage
So
of
we
the
test on the
stent is
LED?
large.
LED, ouais.
Okay.
Donnez le 5-5, vous l'avez? Ou 5-0?
The 5-0.
Who is using
That's LED.
pot side pot in that kind of left main instead of kissing balloon?
Yeah, again, I can say my personal perspective. Pot side pot is very unpredictable regarding the position of the second pot balloon. If you put second pot balloon too distal, you actually shift metal into the ostium of the side branch. And as you saw, even in expert hands, it's not very easy to be extremely precise on the distal marker. So for large bifurcations with large side branch, especially left main, I think we have accumulated evidence that kiss is better than pot side pot. For other bifurcations with smaller side branch, pot side pot could be alternative, especially if you have relatively small diameter diagonal. In that case, opening with small balloon and then second pot could work. But for left main, I prefer something that is well established, validated, pot, kiss, and final pot done very proximal.
Okay, now we will try to engage the balloon, disengage a little bit of guiding in order to place the balloon inside. Okay, here is okay. What do you think?
Maybe
Test.
we can pull. Yeah, it's okay.
Oh, no, it's okay. It's okay. Okay,
so we
good.
can flare.
Go on, inflation, 6,
Yeah.
and I will push on the balloon. Okay, here.
Okay.
Yeah. So disengage the
So we can
guiding
find
and
the
then
room for the
flare
final
the
touch.
protrusion.
Yeah. And I think we are proximal to the bifurcation.
Yeah.
Exactly.
So now we will do, on the balloon, we will re-engage the guiding catheter in order to do the final angio.
Exactly.
I think that we could do it. I hope that.
Yeah.
Okay,
Yeah.
here we are.
Jean, do you think that
So,
in the left main
yes.
it's mandatory to perform a IVUS imaging?
No. To be
more?
honest, I never do that.
No more mandatory.
No, really, I'm not joking. I never do that. I am really surprising by all the people who say today that to know the diameter of the vessel, etc. We need IVUS. My God, it's no. We need a good angio after nitroglycerine and some experience, and you get it.
It really looks
Okay, I think
fantastic.
the
Great
result is nice.
Yeah, it's really great. I really
Now what-
appreciate
We will remove the wires.
and make
Trinitrine.
final.
Okay.
Mais la pression hémodynamique. So you see that the pressure is
Yeah,
good.
pressure is back completely.
Even after all this
Yes.
balloon inflation with kissing 5-0.
Okay.
No, it's fine. Okay, we go. Ready, Bruno?
Yes.
Beautiful.
Yeah.
Beautiful.
We
really.
could do the spider view. So, here. Ready?
Yeah.
Spider view.
No, it's
And there is
nice.
still this.
I think it's correct. And
Yeah,
for me,
but-
I will accept.
Yeah.
The circumflex is not a very
No.
large artery. It's patent. We have a normal flow. There is not a critical lesion. I think
Yeah.
that we can accept this result.
And the last one to see this image that we
Yeah.
had in the previously.
Okay.
You get it?
Yeah.
It's better.
It's
Yeah,
better.
It's much better.
Even angiographically is better after kissing and after shifting Karina back. So we have 2 more minutes, Jean.
Certainly,
One
you
of
know
the
the
cru-
proximal LED that we could see.
Yeah.
Yeah.
If you stay in the room, we can give you a couple of questions which came
can
with
exchange here from the
time
room.
to react. Yes. So, what is the plan with the aortic valve? When and what kind of valve you are going to?
It's your patient. So, Jean, you can.
No. It's true that I know the patient. Now we have time. It's not an emergency to do the TAVI. I think it was more really urgent to do the right coronary artery lesion, and now the left coronary artery lesion, the proximal left coronary artery lesions. Then now the patient will recover from this PCI, and then certainly we will organize the TAVI procedure for the next month. I think we can wait 1 or 2 months. We will see with him, we will see with this family, we will see at what time we will prefer to do it.
One last question is what kind of medical therapy you will give after this procedure? What is the usual practice we need to share with colleagues?
So it's quite a simple therapy based on aspirin and clopidogrel. Aspirin is 100 milligram per day, clopidogrel 75 milligram per day. When we try in routine, we propose to the patient to keep this treatment for 1 year in this kind of left main lesion. If, of course, the patient has some bleeding, etc., we will shorten the duration of the dural antiplatelet therapy to 6 months. But I think that we will try to give him for 1 year.
Jean, I would really like to thank you and your team. We really enjoyed 2 cases. And if you want to say a couple of final words and close the session.
Oh, the final words will be what I say during the opening ceremony. I don't know if some of you were looking at the opening ceremony. I think that it's the 30th anniversary of PCR. The first course was called First Complex Coronary Angioplasty Course 30 years ago. And we didn't believe at that time that we will be here 30 years later, of course, with new partners. And but now it's becoming an old partner, Bruno. And why the success, I think, of this course is because we try to organize, a platform for open exchanges and to tell the truth. I think this is very, very important. We are, all of us, we have adult cardiology in the majority. There is some fellows, but the majority of the people are coming every year at EuroPCR at adult cardiology. They are cardiologists, others, we are peers. And I think that when we really discuss a case, we have to discuss the case with honesty, clarity, to avoid the conflict of interest, the potential conflict of interest. And again, tell the truth. And in other words, tell how we are working in daily practice. Tell how we are working if at the place of this patient, it will be my father. We have quite close the same age. And this is, I think, the basics of the success of EuroPCR. So I will enjoy I hope that you will enjoy the rest of the meeting. With Bruno, we will come back this afternoon to Paris. And I hope to see you tomorrow, this evening or tomorrow. And again, do not hesitate. What we say today, we are all of us companions. This is true. And I invite all the faculty of the course to discuss in the corridor, in the lounge, in the companion lounge of the different type of procedure. I think this is important. But the most important is trust.
Thank you very much, Jean. Have the rest of afternoon. And I thank you also to Terumo for organizing this symposium. I'm sure we made more companions after this symposium. Enjoy the rest of the meeting. Thank you.